Good morning.
Good morning.
How is everyone today? Great. Glad to see you all. Welcome. Welcome here to our town hall. And my name is Mary Bradley. I'm the Director for Healthcare for Army Residence Community. I'm glad that you all joined us today. We have an informative presentation for you. In my role as a Director of Healthcare, I am responsible for the assisted living, the Lakeside Assisted Living, as well as Crestway Assisted Living, and our skilled nursing facility. So I'd like to take a moment though to introduce our folks here, and then we'll get started. So we have Deborah Settles, who is our Director for the social work. Deborah?
Hello. Hello. I'm the social worker in healthcare.
Okay. And then we have Katasha Thomas, who is our Business Operations Manager with Senior PsychCare. Welcome.
And I just want to say, y'all, I'm an Army vet, so HOA.
I'm an Army vet, HOA, right? And my husband's a retired Army veteran, so double HOA, right? So I was like, this place is so lovely, we should retire here in a few years.
Yeah. What's your name on the list?
Yeah, that's right.
Well, it's a real pleasure to meet you. I'm Sebastian LaRoche. I'm the Regional Director. I oversee our operations for senior psych care across all of the southern part of the state of Texas and the state of Louisiana. And I'm excited to be here with you all.
Okay, we're going to turn it over to Sebastian to get us started with our presentation.
All right. Hello, can you hear me? Good? All right, excellent. So I am excited to be here with you all and get a chance to share a little bit about what senior psych care does. We work in your assisted living and your, I think I'm going to hold this. We work in your the assisted living and in healthcare, the skilled nursing facility that you all have here on this beautiful campus. And we're excited to share a little bit about what we do and provide a little bit more context for, we have the opportunity to care for your loved ones. So I think IT kicked in. All right. We really do believe that there's no greater honor than the care for the very young or the very old. You know, every nursing home, every assisted living, every facility that we're working with varies in age. And, you know, we really believe that this is about serving our mission for the whole community and the mission of having a better quality of life, not only for our patients or here, the residents, also working very closely with the facility staff, knowing that, you know, they are the workhorse. They're following up with our patients every single day, making sure that everybody's safe. And of course, we also think about the family, right? We're talking about our loved ones are in the facility, but we have questions. What's happening? Who's taking care of my resident, of my uncle, my grandfather while they're in the facility? And what's happening? Why are they changing medications? Why are they doing therapy? What's really happening within their mental health? You know, they're transitioning in life, and who's helping them in that process? And so with that, I'm gonna share a little bit more about who we are. And so senior psych care, we really focus on the long-term care community. I know there's a lot of words on that slide, but what I wanted to highlight is that this is about creating an environment. It's about truly partnering with a facility, with, you know, Mary and the team here to be able to provide a safe environment, one that's supported, one that's clinically proven as well, so everything's evidence-based. We started off as a psychiatry practice in 2006 in Houston as a geriatric psychiatry practice. His wife, being a therapist, actually then brought in the psychiatry and the psychological side, and that's how we ended up really growing and serving as a family practice. And we've continued to grow throughout the area just by really focusing on patient care, having strong providers, strong team members that are focused, that are passionate about what we do. And so we're Texas-based and just happened to make it out here to San Antonio about, I guess it's maybe been about 8 or 9 years now. And it's been a big part of just being able to provide better care across the state. Our big focus is, of course, on keeping those same Texas values, I would say, showing up with compassion, being a neighbor, and just being a familiar face. We focus on the short-term rehab as well as long-term care, and we really focus on several different conditions, you know, looking at things like depression, anxiety, dementia, schizophrenia, just to give you a little bit of a flavor of the next couple coming slides. And overall, our mission, is always to improve the quality of life. We work very much side by side with the facility, coming in on a very frequent basis, and I'll share a little bit more about that. Part of that is working with the care team and really being part of that partnership is important so that we're all on the same page. So since our humble beginnings in Houston, we've really grown quite exponentially, and part of that has been about being able to serve the broader community. So we serve over 15,000 patients each year, and we're in over 400 assisted livings and nursing homes. And so this is our focus, is how can we continue to improve our services to better serve you and your loved ones. And what's unique about us is that we also have 9 board certified psychiatrists. The psychiatrists are not only providing support to the psychiatric nurse practitioners and our psychiatric mid-levels, but they're also visiting patients. And so they work not only on a supervision role, but they also go and visit patients as well. So they have the experience of working in the nursing home space. We also have over 75 therapy providers in our practice, and we really function as a whole practice where we all work together. And so we're learning from what's happening, what are some best practices in Dallas that we're bringing here to San Antonio? What's the best practices of San Antonio that we're bringing to Houston? And so as a part of what we really focus on is how we as a team on our side are working every day to improve the patient's care, things that we're learning, things that we're trying to address. How can we continually learn and be at the forefront of mental health for all of our seniors? And then in our back office, we do have a pretty strong back office team that's really providing that support for this field team that you probably will interact or see walking through the different halls. What's also unique about us is that we really do almost 99% of our visits in person. So we don't do telemedicine very much unless it's in the crisis situation. And I share this because it's really hiring mental health, and in this field of mental health, you've probably heard of workforce shortage issues, and the fact that we make this a priority to be in person with you is something that we really do take a lot of pride in, and I think that drives better patient care. And then we've been serving not only Texas, and as you heard, I've now served over the Louisiana market as well, and we've expanded to Oklahoma. But just to give you a little bit more of a flavor of who we are as a company and as truly a practice, and how we really want to provide additional support to your team. So I really thought a good way to get us started is talking about psychiatry and psychology. Many of you have heard the terms, or what I want to do is really share this in a way where we're talking about mental health as 2 different components. You have your psychiatry, which is your medication management. They're going to be focusing on treating the behavioral health issues through medication and managing those regimens, adjusting that case. What we really want to do is have our psychiatry reduce the medication so that you have a better quality of life, you're not sedated, the team's supported. But how do we do that? We do that by complementing it with psychology. So it's almost the other side of the mental health coin. And that psychology is focused through behavioral health interventions, meaning really through talking and explaining, figuring out why are the behaviors being triggered in a certain way. What can we do to improve your cognitive function? And then taking a lot of that together through a collaborative approach, bringing that information back to work with the care team, working with your medical director or your primary care doctor, working with the staff at the facility. They're such a key part of the care. And then developing really a comprehensive look at the care plan so that we really are looking at how do we reduce medication dependency. Through this care, we also find that we're reducing rehospitalization rates. And ultimately, we're really trying to help the team at the facilities stay, right? Because they feel that they have the support as well. So it's part of really a partnership, and I think that's why we enjoy working here. What we know is that the need for mental health, for psychiatric and psychological care really has increased over 55% since just 2021, just in the last 3 or 4 years. And the recognition of what happened after the pandemic has been a big driver of recognizing that this communities that we've been serving have been underserved. And so we've really been making a big effort to make this part of a priority to you all so that you know what's happening on the mental health front. We know that, I think THCA even said that 55% of all nursing home residents do experience some sign of depression, right? And so we know that mental health is important. I think we've recognized that over the last coming years, the importance of addressing people's mental health, their depression, their anxiety, PTSD, if they have any diagnoses like schizophrenia, bipolar. These are all common, the things that we're experiencing, and everybody's coming in an environment like a assisted living or a skilled nursing facility where different personalities are coming together and they're neighbors, right? And so how do we continue to provide that support? So things to look for really on a psychological front, if you're experiencing grief, depression, anxiety, those are the type of things that we want to be there to support you through. We're looking at the medications that you're on, that you and your loved one may be on, looking at anti-anxiety medications, antidepressants. On the occasional, we'll look at antipsychotics and hypnotics, but I'll talk about that separately. And then we look at, sometimes we have our loved ones and we see them and they're, having an outburst, or they're acting in a certain way that's a little bit harder to manage, right? And so what can we do from a behavioral disturbance perspective? How can we really work with the team, with your loved one, to be able to address their needs? We work of course, with post-traumatic stress disorder, patients that are experiencing paranoia, hallucinations, fear, things of that nature. And then the big part is, a loss of apathy, and making sure that there isn't a loss of interest in their old, they used to go out and play bingo every day and now they don't, or they used to play poker and they don't. What's the change, and how can we really be part of that support? And of course, there's other changes that are happening, right? As we age, just talking about loss of appetite, loss of energy. Those are all components that we want to look at and see how the physical components are all working together, and how we can support some of those physical components that sometimes are really in mental health. So what does psychology look like? I want to set expectations, right? In terms of when someone says they're being seen by psychology, what we're talking about is really one-on-one sessions where our clinician is working with your loved one, and they usually will spend 45 minutes to an hour, and they focus on developing truly personal relationships with the patient. They are understanding where their needs are, and then they're developing they're assessing for medical necessity, right? Due to the situation, does this patient really need the services? Then we focus on developing a treatment plan that's very specific to each of the loved one's needs, figuring out how do we move them into the right area, how do we support them. And so, when someone's experiencing loss, grief, for example, or loss of appetite, or a change in mood or personality, or they become aggressive, these are all things that our team will review and they will evaluate, and then develop a plan that's appropriate for care. We focus a lot on just even the patient's cognitive functions, right? If we have anybody who's got dementia, we want to look at your cognitive functions and how can we make sure that you're going to benefit from therapy, and what is the appropriate treatment. And so all of that is one way that we really support the resident. The other way is we will also even do family therapy, which is sometimes appropriate for us to bring in the family, and sometimes the family members themselves need a little bit of support when they're seeing their loved one moved into an assisted living or a skilled nursing facility. On the other side of that coin is the psychiatry, right? That's your psychiatric components, and that are focused on medication management. And so whenever there's a referral out for psychiatry, what we're looking at is we first do a psychiatric evaluation, making sure that the medications, that the diagnoses that are on that patient has are appropriate. We will do evaluations and assessments to determine any of those diagnoses. We will then do an in-depth review of previous history to revalidate the diagnosis, right? If someone has schizophrenia, for example, at the age of 82 for the first time, we all know that a patient with schizophrenia would have experienced that at the age of 30, 40, 50. There would have been a history of that background. So oftentimes what we're doing is revalidating those diagnoses to make sure that they're accurate, so that the medications and the treatment plan are appropriate. And we're doing cognitive impairment assessments, making sure that the patient, what's their cognitive status, how are they doing, can they benefit from psychiatry, can they benefit from psychology, how should we approach the patient's care? And then we're looking at every 6 months, we're even looking at all the medications that the patient's on and saying, okay, are these antipsychotics appropriate? Should we be reducing those medications, changing the dosages? So what we do is what's called a gradual dose reduction. You'll hear this sometimes if you're talking to your our psych provider. And what they're really focusing on is bodies change over time, right? And so our ability to eat changes, our sleep changes, all these patterns change. And so if we are on the same medications when we're 40, those same medications may not work when your body is 85, right? They're not going to have the same impact. Your body's going to metabolize it differently, right? And so what we're doing every 6 months is that we're reassessing what that medication dosage and reducing it so it's appropriate to your patients, to your residents' care. And so that's why we'll sometimes have those conversations saying, it's time for us to do a gradual dose reduction, reduce those antipsychotics as appropriate, and I apologize, and working from that end. And so part of this is really about making sure that the medical needs are being met, and then having a system behind how to really manage your medications long term. What we do is really about creating the synergies between the two systems, right? You have the psychiatric side and the psychological side. And when they are working in tandem, we see almost 110% improvement in patients' care, right? So when you really have that combination of psychology and psychiatry, we're able to get to really the root causes rather than focusing on medication management alone. And we're able to really provide better support. So we're improving not only the environment that our loved ones are in, but also we're working on reducing those medications. As we age, we sometimes will bring on other new medications for diabetes and heart disease and other things as well. And so how do we ensure that someone's not taking 3 times the same dosages for the same medication? So that's a big part of what we're doing, and that collaboration is really critical between psychiatry and psychology. A lot of it is focused on, of course, prevention, right? ultimately we're trying to we come to the facility. Psychiatry will be seen probably 3 to 4 times a month. They will be in the facility. Patients may not be seen 4 times a month, right? That would be, but if it's appropriate, they may be seen that often. Some patients may be seen once a month, right? So it's going to vary. But the thing is, we have our staff, our staff will be in the facility at least that often, right? And so what that means is, when they're needing to reach out, something's going on, there's a change, we're already on site and we're able to step in as necessary. On the therapy side, we're coming in to a very similar frequency of 2 to 4 times a month, as well to the home, to make sure that we're spending time with the residents, spending time. And so here we have Stacy Johnson, who's serving this home here, and she'll be coming in a couple days a week as well. And so I really wanted to introduce that this is about providing that comprehensive component, because we could identify changes in how your loved one's walking or a change in their appetite, we may be able to intervene sooner rather than later, before there is a true crisis and we have to send our loved one out to the hospital. Because we all know what happens once they leave to the hospital. It takes so much time to get them back reacclimated to their environment. They have to readjust the medications. And we're working really closely with our care team to be able to do that. And what we focus on is on that collaboration component. And so that collaboration is actually a unique model. It's called the collaborative care model, to introduce a little bit of a vocabulary here. And what it is a structured approach on how we treat mental health in the primary care setting. Assisted living, skilled nursing, that's a primary care setting where you have a medical director or a primary care doctor who's really in charge of the patient's overall care. And so what we do is we work in tandem with the facility staff, care managers in that sense. We're working with our psychiatrists and our psych providers, as well as our psychological and therapy providers, and working hand in hand with the primary care physicians. Ultimately, it's about really looking at mental health as a chronic disease. It's a long-term disease, and rather than focusing on just the acute or the short-term instances that we may be experiencing, and thinking about how do we improve mental health for the long term. We actually expanded on that model a few years ago, when we were started, to recognize that if we think of care as just being about the medical director and the psychiatry and psychology, we're probably missing the key players, right? The other team members. So we've expanded our collaborative care model to expand to include our pharmacist, the pharmacy consultant that the nursing homes and the assisted living have. We're doing medications. We're also rounding, which means we're bringing in all the people that need to be part of the care team on a monthly basis, or every 30 to 90 days, I should say. So on the psychological side, we're working with facility staff. We're providing additional educational resources. We're doing, as well as testing that our loved ones are getting the right treatment, they have the right diagnosis. And we'll work with the families. I mean, if you don't think about care as a holistic perspective, we're gonna miss out on the information that our own family members can share. And so this really is how we approach our care, is through this collaborative care model. We may only be 2 of the 6 elements in care, but this is just how together in that partnership is really critical. And one way that we continue to ensure that we're doing that collaboration is through, we call them behavior rounds. You may hear different, if you're in the hallways, you may hear them called ID team meetings or interdisciplinary team meetings, or different structures like that. And so I share that just because if you're walking by and you're thinking, what's happening? Why did 8 people off the staff just go into a room and talk? What they're doing, probably they'll go around lunchtime or something like that. But essentially what we're working on is developing a care plan for each of the residents and making sure that we're providing the latest information. And so every 30 to 90 days, we're making sure that we're bringing in the medical director, our psychiatry and therapy practice are coming together in person with Mary and the team to talk about how's everything going? Are these medications appropriate? Should we be reviewing the patient's care? And so really, we break that down into a plan. We're looking at our quality measures, making sure outcomes are appropriate, making sure that patient care is appropriate. We're also looking at information that we want to share, right? There's things that we only gain that maybe we share with our medical doctor when he's talking to us about diabetes, and maybe you share a little bit more information that changes maybe the course of treatment that ought to be happening on the mental health side. And so how do we make sure that the information's being shared from the physical side to the mental health side and vice versa? This is one way that we do this, and that's a big part of our goal, right, is to reduce those medications and to improve behaviors as well. So that's just an overview of psychiatry, psychology, our practice, and what we do. I really wanted to just take this time to open up for Q&A and see how I can help answer any questions about our team. Katasha's here as well as our operations manager here in San Antonio, and I think you're only maybe 12 minutes from our central offices, so we're happy to help answer any questions.
How are you compensated?
So what we do is we bill through the residents' primary care,
Like TRICARE?
Yeah, we have a delegation agreement with TRICARE, so we're in network with them, and so we'll bill TRICARE directly. So you will never receive a bill directly from us. So we will bill directly to TRICARE, and then we process it through them. Sometimes you'll receive a letter of benefit that basically says you may receive a subsequent payment from Senior PsychCare, but we do not bill directly to our residents.
Oh, another question I had a friend here who had her father was in hospice, and she wanted really badly to have a psych consult on his medication because they often ordered like some type of psych medication to control behavior. And since he was a hospice patient, it didn't happen.
So part of the hospice patients have a different, sorry, I feel I'm a little loud. Hospice patients require different requirements in terms of who can provide the care. So from a psychological standpoint, it could only be a PhD, right? Someone who's got, a licensed professional counselor or a therapist wouldn't be appropriate for that type of care. On the psychiatric front, you also need that MD. And then there's other models where we can work with our team to be able to provide the care there as well. That's a great question, thank you.
this is related to the same question she asked, except in my case, do you accept, the TRICARE is my third, so I have a state paid insurance which is before TRICARE, so do you also deal with them?
Yeah, so we are in network with
Blue Cross and Blue Shield?
Blue Cross Blue Shield, Humana, Optum, Medicare, Medicaid. And so typically, so we don't bill the same part as so you'll see on if you're in a nursing home, you have Medicare Part A, and you have Medicare Part B. So we bill the Medicare Part B portion, and then Medicare does their audits every year, and they review, make sure medical necessity and documentation are accurate, and so they highlight that part to make sure that since they're the ones who are paying on that front, and then we really provide that from that perspective.
Okay, because TRICARE won't pay if somebody else pays for it.
So what we'll typically do, so if we're saying Medicare is your primary, and then there's a secondary being TRICARE in this example.
And my
Well,
secondary would be my state insurance. I'm a state employee, retired, so that would be my secondary.
so what we'll,
And
yeah,
then,
we'll,
and then TRICARE after that, so they hard to say.
speak up, please.
Put your mic close to the mic.
I'll repeat the
Can you
question
hear me?
as well.
Okay. I thought it was so loud. Yeah, so my insurance is first Medicare, and then it's a Texas insurance that I got retired from, and then TRICARE is my last one, so right now they hardly pay for anything, but it's okay. And then getting appointments, how do we make an appointment with one of your?
So I'll first answer the first question around the insurances. What we'll do is we typically will bill Medicare first, and then we'll bill your secondary afterwards for, from that perspective. So it's usually a smaller portion. In terms of and then the remaining balance, you won't get a bill from us. You may get a letter explaining that there could be a bill, but you won't receive one from us. In terms of an appointment, really what we do is we work through the care team. All right, so so your medical director in the nursing home or your assisted living will have to first do an evaluation and assess, and usually they have to make the referral out to us. And so we really require Deborah and the rest of the team to really be the ones who are going to do the documentation to make sure that we're properly referring out for psychiatric and psychological.
Okay.
And so, if you're experienced, if you want to talk to your PCP about it, that's who I would talk to. Also, you could talk to the social workers or the directors of nursing. I'm not sure if you have an additional process here, but if you talk to anybody, if you talk to Deborah or Mary, they'd be happy to help on that conversation about how we provide services. We don't do by appointment, because we're coming in here, we're spending probably half a day or the whole day here. So we will typically talk to the team first and say, is there somebody we should prioritize? Who do I need to follow up? But we also are using because we're developing treatment plans, we also know, okay, I saw this person 2 weeks ago, I need to check in with them this week. And so that's typically how they'll change their schedules as appropriate.
Okay, well, thank you.
That was a really good question as well. Thank you for these great questions. I'm coming.
My question is, do you do independent, for people who are on the independent side, do you do care for them as well?
We have been working with the team here, and we're continuing to explore the option. Right now, we do not do care for independent living, but we continue to think through that.
Do you have a list of psychiatrists that are geriatric psychiatrists in the area? It is very, very hard to find them.
I think in the state of Texas, there's maybe 400.
That take TRICARE for Life and Medicare. That's the problem. Some of them want $400 up front for each visit. Been there, done that.
So I'm not as familiar with the independent living
really
services, but I know it's something that we're exploring, and I'm happy to try and build any connection I can to support, some of the questions here.
That would be great. Okay, thank you.
I may just want to jump in. Like Sebastian said, we are working on collaborating with Senior Psych to try to evaluate, really look at opportunity on possibly what we can do, working with the primary care physicians that see most of you all here, to find out, their willingness to be on board with referrals and orders between Senior Psych and your doctor. So we are looking at that, and at some point we might have surveys or opportunity to get feedback, whether yourself, your neighbor, your spouse would be interested to get an idea of the volume that we'd be talking about. But we do think there's a lot of potential opportunity to be of service. Like you said, depression, anxiety, coping, environmental changes, a lot of things that people are struggling with. So we want to be sure we're looking at ways that we can be supportive. So we look for other opportunities to do that, and we're evaluating that now. So Ms. Katasha, any other thoughts from a business development standpoint?
I mean, no, you got it. This came up 2 weeks ago, maybe, right?
Yes.
So we're not just answering it because you said it right. This came up. We actually had a meeting with Mary, set up a meeting to see how we could serve the entire independent living. So it is in the background, in the works. And just to give y'all, I know that you asked about kind of how is it, the appointments, just so you get a smooth, you understand or see the transition after they do the referral. If it's an urgent, let's say something's happening and you need to be seen immediately, it's something happened, there's a crisis. They do that and let us know. They notify us it's an urgent referral, and we'll get someone out here to see you. So this isn't like the memory care or the assisted living, the nursing facilities. Outside of that, we have a therapist. So when we're talking about the psychological, a therapist.
I'm not hearing you.
Can you hear me now?
Yes.
Better? So when we're talking about psychological, we said that a lot. It's just a therapist, right? You have your therapist that you go and talk to. You currently have one. It's Stacy. She comes out here every week. Actually, is she here multiple times a week at this point right now? So she's maybe twice. But that comes weekly. And then we have a nurse practitioner that comes out. Rachel comes out here once a week as well. And so that's how that is. So you can get that, especially for therapy, you can get that weekly. And that's how we know. And so they'll talk to you, check in. If it needs to be that we need to bring in a family member to help with the transition, then that's discussed there. So we really are, we try to support you as much as we can. Yes. And remember to talk directly into the mic.
Getting back to the hospice question, your company doesn't provide care for a hospice patient, but will a hospice company, will they have MD psychiatrists and PhD psychologists that are available to their patients in hospice?
That might be a question better served by Mary and Deborah here, but typically I would say most of our hospice groups understand those regulations and they hire appropriately.
Right, the hospice physician, oversees the care, right, of the loved one, but they do collaborate with other doctors case by case. So if there's a real issue coming up with psych or pain management, they are going to collaborate with other physicians. So there are ways that they can do that, doctor to doctor. So it's a case by case. If there's specific questions, again, to refer that to Deborah or myself, and we would help triage that case by case.
Okay, thank you.
Is your company located outside of Texas, Louisiana, and Oklahoma, or not?
Our headquarters are in Houston, where we started we started in a small little family office, and we have a geriatric psychiatric group, and he was a psychiatrist and just started serving the geriatric nursing home needs, and that's how we started to grow. We now provide services outside of Texas as well, and so in the last 2 or 3 years, we have a psychiatrist in both Louisiana and one in Oklahoma, and we provide services out there as well. But our headquarters are all Texas. They're here. They're in Houston. Katasha and I actually have a satellite office here in San Antonio, so we're both, I guess, local in that sense. But our team members, they're all hired locally, and so we're more of a remote company in that sense, where we don't have the brick and mortar model because we work in the nursing homes. Our facilities are your facilities, and so our team they work at home and they commute to the facility that they work at. Question?
Excuse me, sir, I have enjoyed your talk, but what was your name again?
Sebastian LaRoche.
LaRoche?
Yes, nice to meet you.
Thank you.
This is sort of an academic question. I subscribe to several health letters, and they frequently cite statistics like men at such and such an age, you can anticipate they're going to have prostate cancer. So many people can expect to experience diabetes and so forth. And as we move into the senescence of life, are there any statistics that say at some point you're going to need psychological counseling?
So before you answer that, I was like,
So before I have like 7 lives, right? Before this, I was in mental health for a long time. So just the statistics of mental health is, and look at the room, 1 in 4 people. So just look at your neighbor. So everyone in here, right, will suffer from depression, PTSD, any type of mental illness, right? And also think of therapy, because one of those things, and I'm like that, right? I'm a vet, Army, all that, I'm tough. I don't want to talk to anybody, my husband, right? But therapy is like the gym. So it's not like I need to go because something happened. You should do it preventative, like the gym, to stay healthy. So even seeing a therapist and talking to someone, it's to stay healthy. And think about the transition of life. Like if I had to go into nursing facility, I would be sad, right? It's a disruption of your life. So kind of think of it that way. The statistics is 1 in 4.
so look at your neighbor.
And say I support you. Great question. Any other questions? I'm gonna turn it back over to you.
Anything else?
And I will say in yours, I don't know what the actual statistic of that, but the statistics of it worsening are higher if you do not have some sort of treatment. I don't know the exact specific. We can get you that. I don't know that.
Right. And we're fortunate here at the ARC that there are so many wellness programs, right? They have so many activities and things to help foster that support. So we're glad to be a part of that, reaching out, through Lucy back there. Hi, Lucy. People know Lucy, right? And getting you connected, through activities also. There's so many things to do here to foster that. But, our senior psych partners are there as a resource. So if we're encountering those challenges, just reach out to any one of us. We'll help get you connected. So we appreciate it. Unless there's other questions, thank you so much for coming today. We appreciate that. Have a good day. Thank you.